Okay, hopefully you've had a chance to read Colin's case review. Goes into all the main parts of his history and also his past lab tests. What I want to do is just go over some of the concepts that are important that I've highlighted here in the case review, and then discuss what's important as far as what we need to do in a physical examination and workup, and with some of the things that he shares with us, tells us about his potential diagnosis. Now, Colin's 27 years old. He's been diagnosed with Hashimoto's. If you have read through the file, when he was in high school, he's on T4, he's on T3. He's also a very exceptionally young man. He's gone through and, as a non-healthcare professional, gone through all the Kraussian Institute courses and has really taught himself how to support his autoimmunity and neuroinflammation. And you can see he's taking lots of different nutraceuticals for that. His main complaint, if you look at his list of what he wrote down, and I highlighted these, first of all, it's poor brain function. And he writes, brain function, majority of the time, easily reaches threshold. Easily reaching threshold means that it doesn't take much to stimulate his brain, and then it fatigues very quickly. Very difficult time with focus and concentration. Focus and concentration is frontal lobe, prefrontal lobe. Poor mental energy, so that lets us know his mitochondria and his neurons are not efficient. Prone to irritability quickly when stressed. Prone to experiencing bouts of depression and anxiety a lot of the time. I've also started to experience feeling like my brain is rattling in my head the past 1.5 years, almost like my brain feels like it will go through intermittent periods of shaking and vibrating. Recently saw positive markers for antibodies to myelin basic protein. There's a lot of stuff here to discuss. So right off the bat, when you see poor brain function and the main issues are focus and attention, focus and concentration, we know it's prefrontal. And then if you really see concepts like threshold, like easily reaches threshold, like easily gets stimulated, poor mental energy, that just means his mitochondria in his brain is not efficient. The frontal lobe is also involved with depression. So studies in depression showed decreased frontal lobe activity. And we went over those in the mood course. And then the frontal lobe activates suppression of the amygdala. The amygdala is the area of the brain that causes anxiety. And if the frontal lobe is not working and it can't activate the basic ganglion direct pathway that dampens the limbic loop, you can get anxiety. So these are really more frontal lobe. And then people that have had various neurons close to threshold because the mitochondria are not healthy and they spontaneously fire will have all different types of symptoms. Rattling in the head is what he's describing. Shaking, vibrating, that's what he's describing. And he also has antibodies for myelin basic protein. Now, when you get a chance to read the Colin's case review, you can see some really important things. One of them is layers of dysfunction associated with his brain. So up until he was in high school, he finally got diagnosed with ADHD. He actually asked his parents to take him to a psychiatrist to make the diagnosis, and he then ends up with hypothyroidism, and hypothyroidism obviously has impacts on the brain. In many ways, thyroid hormones impact neurons, they impact microglia, so inefficient thyroid hormone activity can definitely have an impact on the brain. There's also cross-reactivity with TPO antibodies and cerebellum tissue. We talk about all this in the Hashimoto's course, if you remember. And we also know that he's got several traumatic brain injuries in high school, playing football, and that he has antibodies confirmed, myelin basic protein antibodies. He's got neurological autoimmunity to his brain. So he's got multiple layers of dysfunction. So the ADD, ADHD just wasn't able to grow out of it. So that means his neuron white matter branching wasn't efficient during his development, usually around 21, 22, 19, 20, 21, 22. All the white matter myelination is complete. So, he really has gone from like childhood ADHD to adult ADHD in combination with the brain injuries, in combination with hypothyroidism being due to Hashimoto's, and then now myelin basic protein antibodies. So with the amount of trauma he's had to his brain, it's very clear he probably has glial priming and this constant neuroinflammatory system. Now, when you look at all the things he's doing here, he's taking many things to dampen neuroinflammation. Neuroflam is a bunch of flavonoids, dampen neuroinflammation. Turmeric, resveratrol, dampen neuroinflammation. Green tea extract, pine bark, dampen neuroinflammation. Bacopa dampens brain inflammation. Glutathione dampens brain inflammation. So there's persistent patterns of neuroinflammation. And he's doing all the right things that you should do for inflammation, but when you really look at the main mechanism here, it's really his mitochondria that's really failing. So there's going to be some really important investigation to his endurance levels and what kind of things we're going to evaluate when we see an exam. When we see an exam, we really want to look at his endurance levels, and endurance levels for the brain and the prefrontal cortex associated with focus and concentration. Be like seeing things like when we do a history, does he really get tired? How long does it take for us communicating during a history and physical exam before he's totally exhausted? Do we start to see facial paresis come out? Do we see his pupils start to dilate when he gets tired? Do we start to see changes in his limb and posture when he gets tired? What happens to his ability to produce words? All those things are things we're going to be looking into when we work him up and evaluate him. So you can see once we record the physical exam if there's any change in his functions from the very beginning towards the end, and that it'll be a clinical window to see how his mitochondria function is within his neurons impacting his brain. And the second chief complaint here is digestive issues. Completely cut out grains, gluten, soy, etc. for the past 8 years or so. Helped autoimmunity symptoms, but never helped to fully resolve digestive problems. Trouble digesting fats correctly and easily experienced intestinal inflammation. Went through Datice's oral tolerance course and implemented the veggie mashup and other protocols he had mentioned, and found some relief eating an autoimmune paleo-style diet. So you can see he's done a really good job with his diet when you read through the case review, and his autoimmunity seems to be somewhat in remission, under control. He just has ongoing neuroinflammatory issues that are of concern here. Sleep, he's never been able to feel rested from sleep. Anytime someone tells you that they have not been able to feel rested from sleep, you got to ask the question if they have a hard time staying asleep, they have a hard time falling asleep, and also if they did get plenty of hours of sleep and they still don't feel rested, you're thinking of sleep apnea. Inability to fall asleep, always think of high cortisol as a main mechanism. Inability to stay asleep, always think of reactive hypoglycemia. But with him, he doesn't fall into deep, constant sleep, tossing and churning his entire life. That's really more like sleep apnea. Breathing shallow during the night. We really need he says perhaps may need a sleep study. Of course he needs a sleep study. We need to get a sleep study on him. And even sometimes just a trial with the CPAP can make all the difference. He's got to get oxygen to his brain. Obviously he's got energy efficiency issues related to his brain endurance. And, he's definitely showing some patterns where he may have nocturnal hypoglycemia. And then fatigue, generally fatigued 90% of the time. I drink lots of coffee throughout the day. Try to keep brain function. Take T4 as well. 125 micrograms to no avail. Force myself to exercise as well as days recommended of the 7-minute workout, but generally feel worse afterwards. Okay, there's a lot of things here, so let's talk about fatigue. When you look at fatigue, there is fatigue from the brain fatigue. There's fatigue like to muscles, where the muscles just get tired, and then there's like endocrine metabolic fatigue, or a person just tired no matter what. They just have this general malaise, like hepatitis C that causes liver injury, or adrenal dysfunctions or thyroid dysfunctions. They can all impact fatigue from a metabolic endocrine point of view. Now with him, the fatigue is when you really read the case review and go through it, it just seems like it's really brain-based fatigue. And that just, again, lets us know his brain mitochondria are not working well. Now, anytime you see someone who's got this history of multiple traumatic brain injuries and myelin basic protein antibodies or neurological autoimmunity, you've got to consider the possibility that they're constantly fatiguing their brain throughout the day. So, and if they are, there's no way for them to ever recover. You only have so much endurance your cells can produce per day. And if their brain is injured and the mitochondria are not healthy, it's going to be very impossible to recover if the person constantly exceeds their metabolic rate. Now, here you can see a 7-minute workout causes a person to him to crash afterwards. Now, 7-minute workouts is probably really stimulating his area of brain injury, meaning there's probably a lot of focus, attention, concentration, maybe even complex motor tasks with a 7-minute workout. Maybe he's doing burpees, maybe he's doing jumping jacks. But, when you see someone crash from working out, with his history, you're definitely thinking of brain fatigue as the main cause. Sometimes people that have lots of inflammation, oxidative stress, will have breakdown after a workout and not recover and feel much, much worse because you just have too much inflammation, and the workout, even though it's good for them, has really increased their oxidative stress inflammation to the point where they generally feel much, much worse afterwards. Sometimes they're in bed for days. So I think with him, if it's only 7 minutes, it's probably not a lot of oxidative stress, unless he's doing really, really high intensity. But maybe it's a combination of both with him. He does have autoimmunity in his history. He does have some layers of brain dysfunction that are involved. And then when we look at this here, we see low libido. Essentially non-existent for the past 2 years, definitely frustrating, thinking it ties into general fatigue, poor brain function, exercise, remove all inflammatory foods, take tribulets, flavonoids, take ginkgo, butcher's room, and no avail. So if you look at his hormone profiles, he's got a salivary hormone profile, he's got a urinary profile. His hormone levels have no indication that he has this andropause or any significant imbalances there. And when you look at hormones, hormones are always thought of when it comes to libido. So let me make a couple of things clear. The reason hormones have an impact on libido is because hormones have a very active receptor site response on the amygdala regions for sexual arousal. But if his amygdala is not healthy because he's just got poor brain endurance and poor brain mitochondria and just tons of neuroinflammation, he's not gonna have libido issues related to hormones. If you ever see erectile dysfunction, that's totally different. That's like blood flow dynamics and circulation. But low libido is typically hormones or anything that's impacting the amygdala. I think in his case, with the combination of general fatigue, poor brain function, he's starting making these connections himself to really where his libido is impacted. Which means, if a guy like him, if you put him on some testosterone, he may have some changes in his libido for a few days, maybe in a week or so. But then it just wouldn't work. And then you could really throw off his feedback loops. I mean, he's only 27, so, some things to think about. Now, there's lots of variables and potential for lots of things that are happening here, but we're just trying to look for patterns and try to see what's happening. And then if you look through his history, he's got lots of antibiotic use as a kid that may have had some impact on his microbiome, immune physiology. To some degree, it's hard to say how much. And then, one of the things he puts down here, since I can remember, getting to sleep has always been a huge issue. The problem is getting my brain to slow down and relax in order to go to sleep. This has been a problem since my childhood, continues now into adulthood. So let me explain that for a second. So the frontal lobe has to be healthy and active to activate the basal ganglia to inhibit the limbic system. So that's how it works. The frontal lobe activates, fires into the basal ganglia. These are called frontal striatal projections. And these frontal striatal projections activate the basal ganglia indirect pathway, which then inhibits the reticular activating system and the limbic system so you can calm down your minds. If a person doesn't have this pathway working, then they just have a restless mind. They can't shut down their mind. They have a really hard time falling asleep. They typically have anxiety issues, and it's very difficult for them to just focus and concentrate, and their mind's going all over the place. Now, that's a GABA pathway, and sometimes taking GABAergic supplements like valerian root or things like lithium, that these or passion flower, these compounds that have GABA receptor agonist effect can have some effect, but ultimately it's just the brain projections that are involved. And for some people, taking GABA support may have some impact. For others, it may have little impact. For some people, they have just a honeymoon phase where it has some effect and then it just stops working. But ultimately, when the brain is fatigued, like his frontal lobe's fatigued, and in childhood he had ADHD patterns already showing his frontal lobe wasn't working, but when the frontal lobe's fatigued, then it can't activate this inhibition to the reticular activating system, and then the person has their brain fatigues throughout the day, they just can't fall asleep, and they get into this vicious cycle. And then it seems like once he gets into his vicious cycle, he probably has some sleep apnea and nocturnal hypoxia, where he's just not getting oxygen to his brain. Therefore, his brain's not working. Once I was able to get to sleep, staying asleep was extremely difficult and still is. And staying asleep could also be reactive hypoglycemia. Would wake up, it would be multiple hours until I could actually felt awake. Still the case for me today. So he's just not waking up rested. He's not recovering. He's not sleeping. Basically, there is no amount of sleep that would allow me to feel rested. That is characteristic sleep apnea symptom right there. So we definitely want to, again, get a sleep study, look for CPAP, see what's happening there. In regards to brain function as a child, I remember having a super tough time being able to focus, concentrate for any period of time. That's the whole frontal lobe ADHD pattern. And then if we go through here, high school, 15, 16, he was finally frustrated, asked his parents to take him to get some testing done. He was diagnosed with ADD. I think now they call it ADHD. They're hyperactive or not hyperactive. But in any case, diagnosed with ADD, he was taking Adderall. And Adderall, is basically stimulants. And it activates the catecholamine receptors. And it caused him to have massive amounts of anxiety. Helped him focus, so the catecholamines that are released that are activated by Adderall will help with focus and concentration because the frontal lobe focus concentration pathways are epinephrine, norepinephrine. But if the limbic system is already active and not being gated by these frontal lobe projections, then you get anxiety with it as well. So it didn't work for him. Switched to Concerta, which basically the same thing because it's the same epinephrine, norepinephrine mechanism. Then you can see in high school he's got some concussions. He's got 2 clear diagnosed concussions, and tons of what his coach calls stingers. So these stingers can be pretty serious, especially after the glial cells have already been primed. So this is where we see multiple issues with head injury. And then he goes, I remember getting a concussion and then going out and drinking. And that's like one of the worst things you can do because ethanol is going to have an impact on glial cells. It's going to break down the blood-brain barrier. When you have a head trauma, the blood-brain barrier breaks down anyways in order to get macrophages and T cells in to get rid of any debris from the brain injury. So now you add alcohol, which also thins the blood-brain barrier and activates glial cells all at the same time. It's a really bad combination. And that could be what, things like that, or what it takes to sometimes prime glial cells and get these glial cells to shift their shape into an amboid structure and then stay there and stay as an M1 hyperactive state. We talked about it, as you know, in the neuroinflammation course. Now, there's some also interesting things that show up in his history. I noticed that when my throat felt extremely swollen, it would hurt. And would hurt when I would go to swallow food and eat. When I felt my throat, I would feel and see that as being enlarged. So this is pretty clear presentation of thyroiditis, painless thyroiditis. This hurts, but it only hurts when he swallows. That's because of the mass. Painful thyroiditis, you don't have to swallow. It just hurts because there's infection, inflammation there. Now, when you look at thyroid enlargements, you have really 3 main categories. You have like goiter, which is a permanent enlargement of the thyroid gland. That happens with chronically high TSH for long periods of time. It can also happen with high amounts of HCG for a long period of time. Then you get the thyroid gland to actually change its anatomy and then have a permanent change in size. But that's not what's happening here because you can see it's like the swelling that comes and goes. That swelling that comes and goes is then either categorized as painful or painless. Painful thyroiditis causes swelling, but it really hurts. There's a sign of infection, and it usually happens after a viral infection. Bacterial infections don't typically cause thyroiditis because the thyroid is so rich in iodine, which is has antibacterial properties. But viral infections, especially upper respiratory infections, can infiltrate into the thyroid gland and then cause painful thyroiditis. Now, painless thyroiditis can enlarge the thyroid gland and you don't feel any pain, but if you swallow and there's an increased large, you can notice some discomfort. So it sounds like he's got the Hashimoto's painless thyroiditis. And while he's in high school, they take him to the physician. He gets diagnosed through laboratory work that he has Hashimoto's. Now, in his adulthood, as you can see with his lab tests, his antibody tests are not showing up anymore. So he's done a really good job being in remission, and he's not having to increase his thyroid hormones in his adulthood. So the interventions he's done with his diet, nutrition, and lifestyle up at this point has kept his autoimmunity in remission, which is great. Anyways, he goes on thyroid hormones, feels a little bit better, has the honeymoon phase, and then he goes back to his old feelings, which is typical of people that have Hashimoto's. Remember, thyroid hormones initially dampen autoimmunity and immune-activated inflammation, and also neuroinflammation. And then, basically the immune system adapts to it and it goes back to where it was, and they kind of lose that honeymoon phase of everything feeling a lot better when they first go on thyroid hormones. In about a week, 2 weeks, something like that. Then you see the depression. He's got that, again, that's associated with the frontal lobe not functioning very well. 19, he goes down the rabbit hole. He starts to find the autoimmune paleo diet. He really starts to look at those strategies, and autoimmune paleo diet, notice changes of his joint pain and swelling, his digestion, his brain fog, they all start to clear up. This lets us know that dietary proteins definitely have an impact on activating his immune response, his inflammatory response. And what's interesting is he's got some joint pain and swelling that go away, which means he might also have autoimmunity in those tissues. Anytime someone has autoimmunity, you want to figure out which tissues have expressions when the immune system is activated or deactivated. So when he goes on an autoimmune paleo diet and all of a sudden his joint pain goes away, there's a possibility that he may have some cartilage or joint-related autoimmune target proteins. Now, he did Cyrix-Ray-5, but Cyrix-Ray-5 only tests a couple of the target proteins for rheumatoid arthritis. So he may have an underlying rheumatoid that's not clear yet. Now, we already know he's got the myelin basic proteins. It's not uncommon for that to clear up as his autoimmune response goes down. And then you may even have some digestive autoimmunity. We're not really clear with that at this point. Meaning gastrointestinal target protein autoimmunity. Okay, so then we go on here. From age 19 until 27, spent the entire time focused on learning, trying to do whatever he can to feel better, and he's done a fantastic job. My health, brain function, energy digestion felt like really began to increase from 19 to 23, and then during this time he was 100% dialed in, taking tons of different supplements, really focusing on different strategies to recover. And then if you read his history, things like lithium orotate helped him at some time. St. John's wort was like something that helped him. And you see various nutraceuticals that have an effect at some point and then they stop working. And that's typically what happens with a person who hasn't really have an underlying pattern treated. When you look at neurotransmitter support pathways, they can have some effect, taking off the edge off, and they have a honeymoon phase if the underlying mechanisms are not treated. So if he's got an injured brain, just taking neurotransmitter support may not always make the biggest difference. There's some issues here with mold. This is important to us. You may have developed a mold allergy. Mold allergy is when they have IgE responses. IgE is like a mold allergy. And that means that every time they get exposed to mold, the memory B cells get activated, and then that'll trigger their inflammation if he's got prime glial cells that'll really shut down his brain. So we may want to do some IgE antibodies. IgG antibodies to mold spores just means he's got some exposure and there's an immune response against them. So we may want to do IgG, IgE reactions here. And then, he starts to activate his brain. He's following the autoimmune paleo diet. He's trying to exercise. He's trying to do all the things that make sense from a clinical perspective. Takes a deep dive into all the courses I put together. Neuroinflammation course really seems to help him understand the concept of prime glial cells. He eventually ends up on a carnivore diet, and the carnivore diet really helps him. Now, the carnivore diet is something that we don't completely understand, but we do know it has a clinical effect that's profound in some individuals. So with carnivore diet, there's a few things that are definitely happening. One of them is insulin levels are definitely going down because meats are very low in carbohydrates, so there's less insulin surge. So insulin can activate, the RAGE receptor against advanced glycated end products. Insulin triggers neuroinflammation throughout the brain. Insulin turns on glial inflammatory responses. So part of it could be that his circulating insulin levels go down the carnivore diet. We also know the carnivore diet, has no proteins from things like gluten, dairy, nightshades, lectins, and even more so, a carnivore diet may have a profound change in the microbiome. We have to remember that the microbiome, 1/3 of the microbiome is genetically driven, and when you look at some areas of the world, like, for example, Nordic regions or even like Eskimos weren't eating salads all day. They weren't eating, going down and picking berries off trees. They were basically hunting and just eating meat. And I think for some genotypes, their microbiome is set in a way where they're just used to a high carnivore diet. a high meat diet and a carnivore type diet, and I think it's clear that it worked for some people. Now, he was on the carnivore diet, and then he made some efforts to kind of switch off from that and do the microbiome mashup, but it didn't work for him. Like, it really tended to make some difference for him, and I'm probably gonna consider going to diets that work for him. I have no problem with him staying on a carnivore diet if it's helping him dampen his neuroinflammation until we can address some of the deeper issues, which is like why his brain's fatiguing, trying to avoid that, getting his microglial system to be dampened. More importantly, though, trying to support mitochondria. And what do I mean by support mitochondria? Meaning that we definitely want to get efficiency of fuel to the mitochondria, oxygen, most likely for his case, like ketones. And then also, we got to support mitochondrial biogenesis. He's taking lots of different flavonoids for neuroinflammation. Those same flavonoids activate the same pathways that turn on the signaling pathways for mitochondrial biogenesis. We want to support mitophagy, where unhealthy mitochondria got cleared out. We want to support autophagy. So we're definitely going to be heading towards ketosis, intermittent fasting, prolonged fasting, to support those mechanisms, probably doing normal circadian rhythms. And if things work more efficiently during that time with the low carbohydrate diet, we're gonna have him focus on that. More likely, we're gonna have him go on a ketogenic diet with some healthy fats, probably high amounts of meat, similar to a carnivore diet. Just from reading his history, that's my first impression. Now, once we get a chance to talk to him and do a full evaluation, may change your mind, but that's my first impression reading the case. And then you notice he has good days, bad days, starts to make those associations, so those are pretty important. And then he's get some testing done for like viruses, but these are IgGs. They're not IgMs. They're not as reliable for an active infection. Now, if he has herpes virus 6 virus with an active infection, then you'd also expect to see some clinical symptoms and skin changes and so forth. But we're not clear with the history if that's happening. Gets his myelin basic protein diagnosed at some point. He's working with different practitioners. They try different things. For all the things he tries, there's a honeymoon phase, and then some things don't make any difference. Again, this is not uncommon. You see people that have brain issues, and some things can fatigue the brain and excite the brain if there's too much stimulation with him. Like he takes some mechanical appearance system like dopamine that made him much worse, and then some things seem to really help him that activate the brain. Like caffeine activates the catecholamine, so that might be part of the pattern there. So he tries to work in the autoimmune paleo, get some veggies back into his diet, and he's thinking, well, the carnivore diet worked for me, but I got to get back some veggies in for the microbiome, and he's making some efforts to get some veggies back into his diet, as you can see. Then you notice things like St. John short was a game changer, lithium was a game changer. You get various supplements were a game changer for a period of time, but nothing really lasts. Okay. And then we get into, let's see what else was important here. Timeline sequence, ADD, ADHD, Hashimoto's, brain injury, myelin basic protein. Those are the different layers of things that are there. Okay. So then, he does a pretty good job understanding those mechanisms if you read his history. I always like to look at these questions. What things improved your health? What things didn't help your health? He says so many supplements for the years. Some helped, some didn't help. That's not uncommon. Coffee has helped his brain function to a small degree. Yeah, coffee is probably a really good idea for him. Like, coffee gets a bad rap, but coffee is, rich in flavonoids that dampen microglial cells. And his frontal lobes are not working with focus and attention pathways. And those focus and attention pathways are driven by epinephrine, norepinephrine. So, this is something that's supporting his neurotransmission, keeping his brain active, and also probably dampening neuroinflammation. You can see the mechanical appearance here helped his focus but crashed. And that could be because his dopamine neurons don't have enough efficiency, enough endurance. So if you stimulate them with things that bind to dopamine receptors, and the mitochondria isn't able to handle it, then you can easily crash because it exceeds the neuron's metabolic rate. And then some things work, some things then stop working, making you irritable. And then you can see, basically he takes vinpocetine for blood flow. It helps, but then doesn't put him in a depression state. And then Vitamin Huperzine A, which binds to acetylcholine receptors, works, and then doesn't work, puts him in depression. Again, these are things that are fatiguing his brain. Dopamine, which has been kind of appearance of things, work, but then he crashes. These are all signs his neuron mitochondria are not working. Like his whole battle is mitochondria. Like if we look at the information we presented in the courses, like the neuroinflammation course, all that stuff applies to prime glial cells and brain inflammation and everything. But really, the part of the course material that's going to really be impactful for him will be the course we talked about on pain and fatigue, especially on the fatigue section where we get into mitochondrial efficiency and all the things that impact healthy mitochondrial physiology. Anyway, so you see a lot of those things, and then you see things that cause adverse reactions. Gluten, we know he's got a HLA-DQ reaction. So gluten triggers his brain. His brain's already primed. It absolutely destroys him. Not a surprise. And then he also noticed he doesn't do well when he takes things like echinacea and astragalus. Echinacea and astragalus are definitely Th1 stimulators that increase natural killer cells. So he's got some Th1 responses that he doesn't do well with. And then if you just go through, you can just see some random labs. Oxidase LDL was high here or there. HLDQ was high here or there. Some IgA antibodies. But we'll look at the specific labs together here. Now, this is the Brain Health Nutrition Assessment Form. And remember that in the Clinical Mastership training program, we have a whole section on forms, and there's a key for all the forms. But section 1 is related to just brain endurance, circulation, blood flow. His main issue is low brain endurance. And if you look at the key here, he marks it as a 3. 3 is almost always, all the time. Let's exercise, drink coffee to improve brain function. That's all. That's all. Catecholamine, epinephrine, norepinephrine. So we get this fatigue issue, and his brain's not working. He's got to take coffee all the time. And then brain fog, unclear, section 7. These are all symptoms of neuroinflammation. Brain fatigue when the body's inflamed. This is all neuroinflammation. Section 8 is all the issues related with gluten sensitivity, which we know he has. Section 9 is any past history of autoimmunity. We already know he's got brain autoimmune and Hashimoto's. Section 10 through 14 are different neurotransmitter imbalance symptoms. So decreased serotonin symptoms, or what section 10 is about. Decreased dopamine symptoms is section 11. Decreased acetylcholine symptoms are section 12. Decreased epinephrine, norepinephrine is section 13, and decreased GABA activity is section 14. So you can see all types of neurotransmitter mechanisms. However, when he takes neurotransmitter support, they work in initially, and then they fatigue his brain and he gets depressed. So again, you can't, if the mitochondria aren't working and you stimulate pathways that activate neurotransmitter receptors with nutraceuticals, you can fatigue the brain and cause exhaustion, which is what's happening with him. Now, if we move on to the brain region localization form, this is looking for different areas of the brain where you might have dysfunction. And with him, we can see his frontal lobe, prefrontal area, which includes the dorsolateral prefrontal at the very front of his brain, has symptoms that are pretty significant. And, when we look at these forms, this brain region localization form, a normal response is someone fills these out. There's, mostly zeros and ones, maybe an occasional 2 or something. But if we see 4s, which means they have the symptom almost 100% of the time, or 3s, 70% of the time, then you got a problem. Now, I just highlighted the 4s, but you can see he's got lots of different 3s too, like difficult planning, organizing 70% of the time. Constant repeated events to thoughts with difficulty letting go. You can see that has 75% of the time. Difficulty initiating tasks, and by the way, these are all perseverations. You just can't keep the thought. You have to keep the thought, or the song is constantly in your head. That's perseveration. That happens when the frontal lobe is not working well. You may have experienced a tendency your frontal lobe is fatigued, and you hear a song you can get out of your head. That's perseveration. Decrease in attention span, so pretty much he's got mostly 3s and 4s for all the areas in the frontal lobe. But then when you look at the rest of the areas of the brain, moving a little bit further back to the sides, you don't see many symptoms. When people play contact sports, and especially things like football, the impact is usually to the front of the brain. It's not usually to the side because they're not running with their head turned. And you can see the areas of the brain on the side don't really have many symptoms. Now, parietal lobe is good. Here we see some symptoms associated with the medial temporal lobe, but they're mostly memory symptoms. And when we look at memory symptoms, there's like working memory and declarative long-term memory. And we may have some confusion. We may have some mechanisms here where Memory is less efficient is actually working memory. So working memory means you hear something, and then if you can recall it right away, it's really related to focus and attention. That initial 1 to 2 minutes of memory is working memory. It's all frontal. Declarative long-term memory is like remembering an event from days or weeks or months or years ago. And it's not as clear on this questionnaire form what type of memory issues he's having. It looks like he just may have working memory issues. The medial temporal lobe is really hard to injure from contact sports. The medial temporal lobe is right in the middle of the brain. There's all these other tissues around it that would probably be injured before the medial temporal lobe is injured. And it's unlikely at age 27 he's showing signs of Alzheimer's disease. These are all the early symptoms of Alzheimer's disease. So I think when he says difficulty remembering events, memory less efficient, difficult with memory, a lot of that has to do with working memory. There could be some issues with declarative memory as well. So we can't ignore it. Just have to pay attention to it. Okay. And then, you can see crowded places cause anxiety. The cerebellum is very important to us because for two reasons. Since he has Hashimoto's and gluten sensitivity, both TPO antibodies and gluten can cross-react with the cerebellum, cause molecular mimicry and inflammation and destruction, but we don't see many symptoms here other than crowded places cause anxiety. That could just be from stimulation overload, unrelated to movement and motion that happens in crowded places when the vestibular cerebellum is off. But also, in addition to the cross-reactivity with TPO and gluten with the cerebellum concern, a lot of people that get frontal lobe injuries like contact sports, the back of the brain gets hit from a counter coup. So the brain gets hit in the front, and then it pushes the brain to the back of the skull, and then you get a second injury there. And usually it's the cerebellum or the occipital lobe. Now, he doesn't have any symptoms of any occipital lobe injury over here. Those are all pretty good. But he does have symptoms, and very mild symptoms of cerebellum. So we have to do an exam and see what's there. And then the frontal lobe is key in activating the basic ganglion direct pathway. And since it's not working very well, he can't shut off his mind. He's got these compulsions, nervousness, restless mind. And also when that frontal lobe isn't able to shut down this whole limbic system and get a restless mind, those things activate the sympathetic response, and the pathways from the frontal lobe and basic ganglion direct pathway also dampen sympathetics. So he's in this increased sympathetic state. So tendency for anxiety, difficulty relaxing, episodes of racing heart, difficulty sleeping. So those are all things that are of concern for us. Now, right away, what we want to consider doing is when you get into the physical exam is what's going on with his prefrontal orbitofrontal. There's no direct physical examination sense for prefrontal orbitofrontal other than just seeing what his cognitive function is, his focus is, his attention is, his concentration is, and what his endurance is, as we do in history. And then when we want to look at, we might want to do the Montreal Cognitive Assessment Form, see if he has any kind of mild cognitive impairments. You should always do a Montreal Cognitive Assessment Form if you see this medial temporal lobe section involved, with lots of different symptoms and 3s and 4s there. And then as far as over here, when we see sympathetic and parasympathetic issues, we really want to look at those in the exam. So we really want to look at parasympathetic function. We want to make sure his eyes are tearing. Tearing is parasympathetic. Superior salivatory nucleus. We want to open his mouth. We want to see a really shiny mouth. Shiny mouth means he's got lots of saliva production. That's inferior and superior salivatory nucleus activation. It's all parasympathetic. Be able to swallow. We'll look at his gag reflex. That's 9 and 10. We want to listen to his abdomen. We want to see what's happening with his parasympathetic response. Sympathetic response, we want to look at his heart rate. We want to see if his pupils are dilated. We want to see how he's breathing. See if he's got any dysautonomia. This dysautonomia where there's a lot of sympathetic activity, that may just make his gut less efficient because gastrointestinal function is all parasympathetic. So if someone's in a sympathetic mode all the time, neurologically, it's going to be very hard to make a big difference in the gut. And then this is a section here called on epileptiform activity. Epileptiform activity just means spontaneous activity of neurons. So you have some sudden anxiety, some sudden limbic changes. His heart rate seems to race. We got to find out more specifically what the history of what these are referring to. He's got some tinnitus. He's got some flashing lights, stars, jagged lines. That can happen when there's hypoxia to the brain. So we really want to look at his blood flow, his circulation, his perfusion index, see what's happening with that. Then we get into the metabolic assessment form, and right off the bat, when you look at his first left-hand side, these are all, the first few categories are all related to digestive function. The only thing he really put is increased frequency of food reactions, which, he's identified that being an autoimmune paleo diet makes a big difference for him, so he's got reactions to foods. But for the most part, category 1 are symptoms of dysbiosis. He doesn't have any symptoms, 0s and 1s, maybe an occasional 2. And tolerance to category 2 is symptoms of leaky gut. Category doesn't have any symptoms there. Category 3 are symptoms of loss of oral tolerance. Category 4 is symptoms associated with lack of hydrochloric acid. Category 5 is like gastric ulcer symptoms. Category 6 is pancreatic enzyme deficiencies. Category 7 are symptoms associated with small intestinal bacterial overgrowth. Category 8 are really gallbladder symptoms. He's got some issues with digesting fats. You can see a little bit here. So when you look at these first 8 categories, his gut function is pretty healthy. Now, you have to remember, he's eating a really healthy diet. He's an autoimmune paleo diet, so he's been able to resolve much of his gastrointestinal symptoms. If you just saw this questionnaire form, you wouldn't really think he's got much digestive issues. He puts on digestive issues as second chief complaint, but it doesn't look too bad here. It just seems like it's fats, which is more gallbladder related. Okay. And then we get into blood sugar stability. Everything seems like he's stabling his blood sugar levels pretty well. He just has dependency on coffee to keep himself going. I think that's because he needs that frontal lobe epinephrine stimulation from coffee and the anti-inflammatory effects from coffee to work. And then cannot stay asleep, slow start in the morning, afternoon fatigue. These are symptoms that are associated with adrenal hypofunction, like physiological adrenal hypofunction, but they can also happen from sleep apnea. Slow start in the morning, afternoon fatigue, wake up tired even after 6 more hours of sleep. So, these are all possible there. And then category 16 are symptoms of electrolyte imbalances. He's definitely got some symptoms of electrolyte imbalances, so we want to dig into that a little bit more. Doesn't have any significant patterns when you look at his blood work that's included in this case review. And then he's got all these low libido symptoms, but I think these are more neurological, and not as much related to low hormones, because the hormone profiles seem pretty good. Okay, the neurotransmitter assessment form is just basically showing the same things as the brain health nutrition assessment form, just all the different neurotransmitter imbalances and so forth. Then he's got some history here of taking Wellbutrin, which is a norepinephrine dopamine reuptake inhibitor. Okay, then we get into his labs. So this is organic acids test, and you guys, there's nothing on this organic acids test that's gonna be a game changer. These are different metabolites that check various things. It's a very general screening test, very general screening test for some basic things. This is not very useful for us. And when you look at these neurotransmitter metabolites, these have nothing to do with the brain. These are peripheral neurotransmitter mechanisms. They don't reflect what's actually happening in the brain. So that's not useful to us. Slightly elevation of oxalic acid, no big deal, nothing there. And then ketone and fatty acid oxidation, again, some acetic acid, some hydrobutyric acid on the urine. Maybe he was in a fasting state for a period of time before this, nothing useful there. Some nutritional markers that are there. A lot of these markers are unstable, they're not that great. They give you some general ideas, but just to make it very simple, there's nothing very useful from this organic acids test about his case. Then we get to the GI map, and the GI map is looking at bacteriology, parasitology, a little bit of high Bacteroides Firmicutes. That doesn't tell us much. There's nothing dramatic there to really make any difference for what we need to do with his gut. And then we get into some different serum testing. And I always have a little bit of caution looking at labs that uses microarray analysis. Most labs don't use microarray analysis. I know Vibrant does. Microarray analysis is they're using a small amount of the antigen with their test and then doing a predictive model to see if it's positive or negative. The gold standard is not that. The gold standard is ELISA, where you have clear positive, clear negative. You don't have to do a predictive model. So whenever I look at a panel like this from Vibrant, I'm not as confident if these results are as accurate as they could be, right? Anything with an antibody, IgG, IgM. Now, things like this, like ferritin, iron, UIBC, I don't have any concerns with that. That's not microarray analysis. Those are routine lab work. So these, to me, are reliable numbers. But again, once we get to antibodies, I'm not so confident with some of these responses because of the way the methodology the lab uses. Now, but however, C-reactive protein is not microarray. It's just a standard routine test. So I would feel that's reliable. And then here are some like systemic autoimmune disease antibodies that are all negative, even though he's got joint pain. But once again, these are microarray. And then you see, he's got some LDL elevations. LDL direct is a little bit high. AP protein's high. The question is, do you want to go after all the cardiovascular risk factors right now with someone who's just not getting through the day? I personally don't. And a lot of the things we're going to probably want to do with him, like get him into, probably going to want to do things like get him in ketosis. And that may have a huge impact on changing these numbers in a positive way. We'll have to see. Oxidized LDL is high. So he's got some inflammation to get his LDL. This is a really bad combo, by the way, for cardiovascular risk. LDL is high. And then you get the apoproteins abnormal, so the transport of these proteins, and then you get high LDL with high oxidized LDL. Those are not good. So we went over a lot of those principles in the cardiovascular course at the Crosby Institute. You can see his TSH is a little bit high, just slightly outside the lab range. And then here, if you look at his total testosterone, 768, that's fine. Free testosterone, 10.59, maybe on the little bit of lower end of normal. Certainly wouldn't cause all those low libido symptoms. Progesterone's fine. Sex hormone binding globulin, a little bit high. DHA, a little high. Now, estradiol being a little bit high is a bit of a concern. So there may be, when you look at this, the serum test, then you look at a saliva test, and then when you look at his urine hormone profiles, there's some mild indications that there could be something off, but I still think it might be neurogenic. We'll have to see. Sometimes you go after one thing, like for him, we're definitely going to go out after an aggressive approach for his brain, but sometimes, like they don't work, and then now you're going, okay, well, let's go after the hormones a little bit more. There's going to be practitioner preferences. Some people will start with the hormones because that's where they feel more comfortable with. I'm just going to share with you what I'm going to do with him, and then we'll have to see how he responds, and we have to readjust or do other things. It all depends on working through the case. Okay, then here's his Dutch urine test. With the Dutch urine test, you can see, his sex hormone levels are actually pretty good. He's got a delayed sluggish cortisol awakening response. That's not good. We definitely want his circadian rhythm normal, his cortisol rhythm normal. Now, his cortisol level production is pretty good. So those are all related to the adrenal gland ability to produce hormones. The cortisol awakening response isn't necessarily an adrenal gland functional test. Cortisol awakening response test is a test where light hits the visual pathways. The visual pathways get into the optic chiasma. There's a super optic chiasmatic nucleus, then activates the periventricular cells of the hypothalamus, which then activates ACTH output in the morning in that first 20-30 minutes to get that cortisol up by 50%. It's really more of a neuroendocrine pathway than it is like just an adrenal pathway. So his adrenal glands do work. They make cortisol. It's just the feedback loop to the rhythm is off. So we're going to have to definitely make sure he's doing lifestyle strategies to get up at a certain time. We might even have him get up and work out in the morning right away in that first 30 minutes to get that cortisol reestablished. But we're going to have to sit down with him and do more thorough history to figure out what's going on. So for the most part, you don't see significantly abnormal levels of testosterone. It's within range. Epitestosterone is not very significant here. DHT is within range. Doesn't have any significant severe hormone deficiencies, that are obviously dramatic. Once again, these neurotransmitter tests in urine have nothing to do with the brain. The labs run them, but don't use that to interpret anything that's happening with the brain. A little slight elevation of TSH here again. Not too much. Here the TSH is back to normal. Glucose levels 102. We don't know. Let's see if he was fasting or not. Can't really see it on the report. Doesn't have any symptoms of insulin resistance on his questionnaire forms. TSH is low here. So his levels are up and down. It's typical of someone taking thyroid hormones and when they get tested in the snapshot. And like if he was on thyroid hormones, but the practitioner wanted to have him go off before the test, that could be what you would see. Or, you could be on them and then his TSH is back to normal, or they get cleared at different times depending on when he did the test. But for the most part, you don't see in his history like this need to constantly increase his thyroid hormone dosages, and you don't see really persistent levels of high TSH, right? Like here TSH is fine. T3 here is just a little bit on the low normal side, 66. He's not converting T4 to T3. Those are really due to systemic inflammatory responses. The reverse T3, however, is normal. So you can see TPO thyroglobulin in his adulthood. None of these are positive. It was just only when he was in high school and had that active thyroiditis swelling. So I think he's done a really good job keeping his Hashimoto's under control. And then when we look at a more recent gastrointestinal profile, you can see he's got some patterns of dysbiosis. This may be like I'm only guessing, but I would guess this is like the first panel that looks so good was probably for him when he was on the carnivore diet and has he introduced vegetables into his diet. It fits the timeline of being more recent, and now he gets more of the dysbiosis. So you got to see what he has to do. No sites of infections that are critical. No parasitic infections. Just some dysbiotic bacteria. They do a sensitivity test for those bacteria to give you some clues. And then the Cyrix test doesn't find any patterns of leaky gut. That makes sense with the symptoms he has. He's got autoantibodies to osteocytes, which causes bone loss, but wouldn't cause joint pain. And he's got myelin basic protein that would cause ongoing persistent neuroinflammation. And whenever you see myelin basic protein, you got to worry about how bad this is and what stage it is and how severe it is. So the good news is he's got an MRI in this case review where everything was normal. So we're not worried about severe demyelination or MS, but we still got to do a physical exam and see if we see any subtle signs. So anyone that has myelin basic protein, you're going to look for upper motor neuron signs. So we want to check like Babinski's, Tromner's, Hoffman's, make sure those are fine. Look at his reflexes, make sure he doesn't have hyperreflexia, make sure he doesn't have spasticity, make sure he doesn't have clonus. Make sure he doesn't have any cortical bulbar issues with his cranial nerves. His eyes are tracking smoothly. There's conjugate gaze. All the stuff you would normally do to make sure there's no injury to the brain needs to be done. Once again, here you can see that he's able to make cortisol throughout the day. So his total cortisol output is 36. The range is 22 to 46. So his adrenal glands are working. It's just the circadian rhythm is off. The circadian rhythm is really generated by the brain, and specifically the medial temporal lobe. So this is more of a neuroendocrine related issue. I think if we can figure out how to get his circadian rhythms with his lifestyle, with how he eats and workouts and exercises consistent, these things can change. And then here you can see his progesterone's a little bit high. Like when you see 851 with progesterone like that, that is probably exposure from somewhere, something topical. And then here you see his estradiol's a little bit high, but just 1 point. That's no big deal. Testosterone's normal. Dehydrotestosterone, which is very powerful androgen, those are both normal. So no indications from here that you have any andropause patterns with the saliva test. Then he does some, Epstein-Barr viral pattern. There's nothing that is consistent with, reactivation. There's some IgM against herpes zoster, HHV6. And then this is a recent MRI brain without contrast. And the good news is everything's fine. There's no signs of demyelination, which is great. Having myelin basic protein, you're always concerned about that. So with him, he's got no signs of demyelination. So remember, you have to have like 60% or more injury to the white matter, the myelin sheaths, before you get a signal in the MRI, hyperintensity. So he could be under 60%, or you could just have some neuroinflammation. But the good news is we don't see any hard lesions on the MRI. So again, that's most likely due to the fact that he's been able to keep his autoimmunity in remission, even though he has antibodies. They're not really aggressive, right? Antibodies themselves don't destroy anything. What really triggers the autoimmune response is driving that IL-6 Th17 pathway and not having enough Treg function. That's what really causes the destruction once you have the antibodies. Those are concepts we went over in the Cross Institute autoimmune course. So in summary, when we look at Colin's case, basically we got an injured brain that wasn't fully developed, that then progressed into neurological autoimmunity. We may have some dysautonomia, increased sympathetic pathways impacting digestive function. His brain may be fatiguing, not able to shut down his reticular formation, so he can't sleep. He may have some sleep apnea. This fatigue is definitely brain-based. I mean, this is definitely a brain endurance mitochondria battle. So we got to really look at those mechanisms through the exam and go from there. But there's a lot of great information from his case review that already tells us what direction we need to head in. So I hope you find that useful. Thank you.